Okay, good evening. So we'll start with pharmacodynamics, the fourth video of the general pharmacology. So pharmacodynamics, as we see, like the drug pharmaco, and dynamics means the movement, like effect produced, the effect of drug produced on the body. So the drug is the ligand. It has a high affinity or specificity for its target. The target is a receptor, or it may be any uh, product, like present proteinaceous product, or it may be present in the body, right? So it will bind to the body target then that it produce the product, right? Now we measure it via the dose response curve, means the effect produced is the uh, that is uh, the dose response curve will show the what is the effect. Now the ligand effect is known as the intrinsic activity, right? So what is agonist and what is antagonist? An agonist is producing the effect and antagonist does not produces the effect. So we say the antagonist has zero intrinsic activity. Now the agonist, how much it produces the activity is it's classified into three groups. There is a full agonist, that is the maximum effect; partial agonist, that is the low effect; and inverse agonist, that is the opposite effect, so the negative effect, right? So I is the intrinsic activity. Full agonist has +1, partial agonist is 0 to 1, and inverse agonist is -1, right? So an antagonist, will see that it inhibits the action of the agonist because by blocking it, right? So if you see the intrinsic activity, this is +1, this is -1, and this is say 0, and this is another graph. So we can say over here that this is the agonist, this is the partial agonist, this is the antagonist, and this is the inverse agonist. So this is the that is the intrinsic activity, the activity, or we can say the effect produced by the drug on acting on the receptor. Alright, so now this antagonism, we will see that it inhibits the action of the agonist, right? So it may be of four types: physical, chemical, physiological, and pharmacological. In the physical antagonist, the antagonist bind to the agonist physically, that is the surface get attached. Okay, for example, activated charcoal, that is the universal antidote. Okay, now the chemical bond is formed between the chemical antagonism, and they're like antacid to the HCl, the chelators, the protamine sulfate for heparin. Okay, it is the strongest acidic substance, right? Now antibodies for the antigens. Okay, so now these are the chemical antagonism. Okay, now the physiological antagonism, that means that agonist will bind in the target and produce the effect, right? Physiological antagonist will have a different target but has the opposite effect. Okay, so it will act oppositely. For example, say histamine will act on receptor H1 and produces bronchoconstriction, but adrenaline will act on beta 2 receptor but causes the bronchodilation. Similarly, leukotrienes will act on LT1 to produce bronchoconstriction, and salbutamol, a beta 2 agonist, will act on the beta 2 receptor to form bronchodilation. So they are acting on a different receptor, but they are producing the action opposite. Similarly, PGI2 and thromboxane A2. Okay, now this is causing vasodilation. It has an antiplatelet activity, and thromboxane A2 has a vasoconstriction effect and platelet aggregation property. Similarly, PTH and calcitonin, insulin and growth hormone, or insulin or glucagon, insulin or glucocorticoids, they have a different role. For example, insulin has an anabolic, but the growth hormone, glucagon, glucocorticoids, they have the catabolic role. Okay, so these are the physiological antagonism. Okay, now pharmacological antagonism. Now in the pharmacological antagonism, we see an agonist blocks the target. An agonist acts on the targets and effect is produced, but the pharmacological antagonist will actually inhibit the target, so it is not produced, right? For example, adrenaline and beta blockers. Adrenaline is a beta agonist, and propranolol, suppose it is a beta blocker, right? And they will be acting on just opposite, so they are acting on the same receptor. Okay, now histamine and let's say cetirizine. Histamine will act on the H1 receptor and it will stimulate it, whereas cetirizine will have an anti-H1 activity. So these are pharmacological antagonists. For example, they have two types: competitive antagonism and non-competitive antagonism. In the competitive antagonism, the agonist as well as the blocker will act on the same target. Okay, but in the non-competitive antagonism, the blocker will act on the allosteric site and a different target. Okay, it will be close to the target and it will modify some changes in the target so that it will not bind. Okay, so it will bind on the same site, say it will bind on the same site, which competitive antagonism, same structure, surmountable effect is present, that is overcome the action of the antagonist by increasing the concentration of the agonist. So these are the surmountable effects present in the competitive antagonism. In the non-competitive antagonism, they will bind on the allosteric site, they have a different site and a non-surmountable effect. Okay, now competitive antagonism, reversible blocker is very common more than irreversible blocker. Okay, they are mostly the competitive antagonists, they are the reversible blockers, but the irreversible blockers are also present. For example, okay, for example, this irreversible competitive example क्या हो जाएगा, methotrexate will be acting on the DHFA, folic acid, dihydrofolic acid, candesartan, AT receptor blocker, organophosphate also. Okay, so these are what? These are some competitive antagonism. Whereas in non-competitive antagonism, irreversible blockers are very, very common. Mostly they are irreversible blockers, but some are reversible. For example, acetazolamide, which inhibit the carbonic anhydrase, and this is the non-competitive reversible blockers. Okay, so these are exceptions, and exceptions are questions. Now, you see this graph over here. There is a Vmax. There is something called Km. And there is a response and dose. So there is a dose response curve. There is a dose response curve, and it is very common. You have to understand. Like, see over here, the Vmax, the maximum of this is this, and Vmax about something like this. Right now, there is a concept of potency and efficacy. There is a concept of potency and efficacy. Right? The more efficacious the drug, suppose A and B. So A will be at the same concentration. A is more efficacious than B. So that is more efficacy. A is having more efficacy. Okay. Now, but see, suppose in the C, if A and C are compared, they are producing the same efficacy, but A is producing the same efficacy as a lower dose. So we can say A is more potent than C. A is more potent than C. So in the potency, we can say that A is more potent than C. And in the efficacy, we can say A is more potent than B. Okay, is it clear? Now we can say this competitive and non-competitive. If you will say, now Vmax is in the competitive in normal. Okay, but in the non-competitive antagonism, Vmax decreases. In the competitive antagonism, Km increases, but in the non-competitive antagonism, it is normal. Okay, it is the Km is normal. Okay, now we are not discussing this right now, but basically you have to understand the basic concept. At the end of the day, this table will help you to solve the questions also. Right now, dose response curve, I'll say that the effect is calculated via the dose response curve. The shape of the normal dose response curve is the parabola. That is the parabola, but we take the log of this to make it sigmoid. So log dose response curve is the sigmoid one. So this is the shape of a normal DRC, but this is the log DRC. Okay, now there are some exceptions, like U-shaped DRC is present where? U-shaped DRC is present in the minerals, vitamins and hormones, because either it is the therapeutic range response is present, and after that there is only in the low dose also toxicity and the high dose also toxicity. In the low dose there is deficiency or toxicity, and high dose also deficiency or toxicity. Low dose deficiency and high dose toxicity. Okay, so this is the U-shaped DRC present in the vitamins, minerals and hormones. Okay, the types of dose response curve, as you can see over here, is the graded dose response curve and the quantal dose response curve. In the graded dose response curve, increase in the dose will increase in the response. For example, antihypertensive. Okay, we increase the doses, they increase the response. So one individual we can judge. Okay, now determining the efficacy and potency is there in for one patient, that is the graded dose response curve. But in the quantal dose response curve, one dose all or none law it follows. For example, antiemetic, either antiemetic will work or it will not work, okay, for one population or for everyone. For example, percentage of population is taken, not a single individual population is taken. So we measure actually the effective dose and the lethal dose. We measure the effective dose or the toxic dose, that is the lethal dose, ED by LD. So we calculate by a therapeutic index we calculate by LD50 by ED50. LED लेड we can remember कि ये ऊपर होता है, ठीक है, पहले क्या आएगा LE है ना, L by E होता है, राइट. सो इट इज़ LD50 by ED50. इस तरह से याद करना है. पहले E आता है, अल्फ़ाबेटिकली पहले E आता है, बट इट इज़ द बॉटम वन. So effective dose is the bottom one, right? Now graded dose response curve, we see this kind of graph, and we have discussed about potency and efficacy and how they are measured. So in this graph you'll see that suppose they are having the same response A and C, they have the same efficacy, right? They have the same efficacy. So C, A and D, they have the same efficacy, okay? They have the same efficacy. But the thing is that you have to understand that if you say that suppose this having the same A, so this is A is more efficacious than B, A is more efficacious than B, okay? Because they have a B is the decrease in the efficacy, ठीक है. तो potency में क्या होगा, potency में this graph suppose C, so C is more efficacious than A is more efficacious than D. This is what they are saying, ठीक है. Now forget about this efficacy and potency, ठीक है. Yes, they have compared, we have discussed efficacy and effectiveness. They have a different concept. Efficacy is controlled environment, effectiveness is uncontrolled condition, right? Controlled efficacy is never dose dependent, ठीक है, but is never dose dependent and in the controlled environment. Effectiveness is uncontrolled condition in general population, okay. Now the quantal dose response curve, you can see over here in the cost interval, it is percentage population as well as the area is taken and therapeutic window or therapeutic range is measured, right? Now what is happening over here is you can see there is effect produced in 50% of the population. This is the one graph over here, one graph over here, right? One point over here, right? This is the log dose versus the response in the percentage population. Now therapeutic index is the LD50 by ED50. This we have seen, and this is the safety margin of the drug. This is the safety margin of the drug. Any drug with narrow therapeutic index, requires monitoring, okay. Now the drug effect monitor, the insulin, clonidine, warfarin, heparin, okay, they need monitoring, okay. So the effect monitoring that which cannot measure, if you cannot measure the therapeutic drug, fine. So you see this insulin is like for the blood glucose, clonidine for the blood pressure, warfarin for PT and INR, and heparin APTT. They have these things to be monitored regularly because of the narrow therapeutic index. Now you can see that digoxin, antiarrhythmic drugs, theophylline, lithium, aminoglycosides, antiepileptics, tricyclic antidepressants, ठीक है, methotrexate, calcineurin inhibitors like cyclosporine and tacrolimus, they have the narrow therapeutic index, okay. So basically you have to understand that these parameters are used over here and these drugs are monitored as such, okay. So therapeutic drug monitoring is very important, like where you can do the therapeutic drug monitoring where narrow therapeutic index drug is there is a low safety margin, alright. But if the drug is safe, there is no need for therapeutic drug monitoring. The clinical effect cannot be determined. If the clinical effect cannot be determined, then therapeutic drug monitoring should be there. Nephrotoxic drug in renal failure like aminoglycoside, if compliance of the drug or like for suppose antiepileptic drug, right? Now poisoning of the drug, so these things will allow this therapeutic drug monitoring of this particular drug. Okay, now heat and run drugs, we don't need any therapeutic because they have a safety profile, right? Now active metabolites of drugs and clinical effect is known, so there is no need for therapeutic drug monitoring. Now the types of targets is very important. There is a protein target and some other targets. Protein targets are basically the receptor, ion channels, carriers, transporters, enzymes, right? And other like antacids and the chelators. Now the receptors are 4 types of receptors basically. The 1, 2, 3 are the cell membrane receptor, 4th is the intracellular receptor. So the first is the ionic receptor or the ligand gated ion channels. Now what happens in ligand gated ion channels? These are the pentameric rosette. These are pentameric rosettes. You can see 1, 2, 3, 4, 5. Now the ligands get bind over here and it opens. There will be an ion influx, and then this ion or the sodium or chloride, sodium will lead to depolarization and causing an excitatory response, and chloride doesn't hyperpolarize and it will be an inhibitory response. Okay, now the structure, like it do not need any secondary messenger and it is the fastest one. So this is all about the ionotropic receptors. Now for example, nicotinic receptor acetylcholine is an ionotropic receptor. 5-HT3 receptor serotonin is a serotonin receptor is an ionotropic receptor. NMDA receptor for glutamate, GABA chloride and glycine for chloride channel opener. These are for the ion channel receptors, right? Now the GPCRs, the G protein coupled receptor, is the metabotropic receptors, right? The function is to help of the secondary messenger. Now the ligand will act on this serpentine receptors. The ligand will act on the serpentine receptor. This is a 7th receptor you can see over here, right? And this is the chain. This is the basically the membrane, and this is the glycoprotein. This is the not glycoprotein, this is the G protein. It will stimulate the G protein, which has an alpha, beta and gamma subunit. The alpha will be attached with the with the GDP. Okay, now this is the serpentine helical we have discussed. Now GDP will be, now this is the resting phase because then it is the GDP. Now if suppose ATP will be converted into ADP, and one inorganic phosphate, that is PI, is released. Now it will now bind to the GDP and convert it into GTP. Now this alpha will bind with the GTP and will leave this beta and gamma. ठीक है, अल्फा क्या करेगा, GTP के साथ बाइंड करके बीटा गामा को छोड़ देगा, the subunits को, right? Now what happens, फिर से when GTP will be released, will release the inorganic phosphate. Now again this alpha will bind to the beta and gamma and forms the resting phase G protein. Okay. Now the types of G proteins are GS, GI and GQ type. G12 and 13 is not necessary. GS and GI will act on adenyl cyclase. One is stimulatory, another is inhibitory, or it will act on the guanyl cyclase. Okay, so ये हो गया important. Now this GQ will act on the phospholipase C. It will activate the IP3 DAG response via PKC, and the third messenger calcium is released forming the calmodulin pathway. Now, so this is the first, it will act on the GQ. All the receptors acting via the GQ will be first and the secondary messenger as IP3 and DAG, and tertiary messenger as calcium. But here if you can say GS and GI, it will act on adenyl cyclase. It will increase the cyclic AMP or cyclic GMP, and protein kinase A will be formed, right? But here in the GI, cyclic AMP and GMP is decreased, protein kinase G is produced. Okay. Now cyclic decrease in the cyclic AMP will be causing opening of the potassium channel and causing the hyperpolarization. Now what will happen in the GS adenyl cyclase? I said that ATP will be converted into cyclic GMP, cyclic AMP, and guanyl cyclase will convert GTP into cyclic GMP. Now these all are active. It will be degraded by the PDE, phosphodiesterase enzyme, to convert into inactive form 5' and 5' AMP and 5' GMP. Now there are 5 PDE inhibitor which are excitatory, right? Like sildenafil. They are excitatory because they increases the cyclic AMP and cyclic GMP levels. It will not able to metabolize this cyclic AMP and cyclic GMP. Now the GPCR as the largest family, for example, muscarinic receptor of acetylcholine is GPCR. 5-HT1 to 5-HT7 except 5-HT3 is the GPCR. Other is 5-HT3 is the ionic. Okay. GABA B channel, GABA B is the GPCR. Okay. Alpha 1 and beta are sympathetic nervous system, they are GPCR. Hypothalamus hormones, all are GPCRs. Pituitary hormones, all are GPCR except for the growth hormone and prolactin, and we will see where they are acting. Pancreatic hormone, all are GPCRs except the insulin. So we will learn about growth hormone, prolactin and insulin, how they are working. Pancreatic hormone, glucagon is GS and somatostatin is GI. Okay. Now opioid, olfactory and photoreceptors, they all are GPCRs. Now the third type, enzyme linked receptor or protein kinase receptor. These are the growth receptor also. They are known as the growth receptor. So they have a transmembrane protein, that is the kinase with a kinase. तो kinase का काम क्या होता है? Phosphorylation, adding the phosphate bond. Fusion of the receptor is there and also phosphorylation of the enzyme is there. ठीक है? The enzymes are the tyrosine kinase receptor for the insulin and insulin like growth factor. ठीक है? Serine, threonine kinase in the TGF. ठीक है? Janus kinase, JAK-STAT pathway or the cytokinin in the growth hormone and prolactin, erythropoietin, thrombopoietin, interleukin, cytokinin. They have the JAK-STAT pathway. JAK-STAT pathway, Janus kinase signal transduction and activation of the transcription. So these are the examples, these are where the exceptions, that anterior pituitary के सारे हार्मोन GPCR होते हैं except the growth hormone and prolactin. और यहाँ पे pancreatic all enzymes are GPCR except the insulin. ठीक है? Now gain of function mutation. Now gain of function mutation will lead to ultimately to cancer. Now this thing is very important because you have to understand that BCBR-ABL fusion will lead to 922 translocation causing GIST. ठीक है? Now protein kinase inhibitor like imatinib, last में है, ठीक है, that will be acting against the CML or the GIST. Okay. Now the fourth and final type of receptor you can see is the intracellular receptor, also known as the nuclear receptor, but the term is nuclear is sometimes not used because they have of two types. Intracellular has intracytoplasmic and intranuclear. Intracytoplasmic example is the steroid hormones like everything, glucocorticoid, mineralocorticoid, testosterone, progesterone, vitamin B3, calcitriol is the intracytoplasmic. Now estrogen and PPAR, ठीक है, vitamin A, T3, T4, thyroid hormones. Now these are intranuclear. So vitamin A is intranuclear, vitamin D is intracytoplasmic. C के साथ D जाएगा, याद रहेगा, ठीक है. और यहाँ निमोनिक क्या है? टेप में क्या आ जाएगा? टेप में आपका आ जाएगा T3, T4 थायराइड हार्मोन्स, ठीक है. ए से विटामिन ए, पी से PPAR और ई से एस्ट्रोजन, ठीक है. नाउ दीज आर द स्लोएस्ट एक्टिंग रिसेप्टर. Now the common property of the receptor is the promiscuity of the ligand. That means it binds to many receptors. ठीक है, इट बाइंड्स टू मेनी रिसेप्टर. लाइगेंड कैन बाइंड टू मेनी रिसेप्टर. फॉर एग्जाम्पल एड्रीनलिन अल्फा के साथ भी बाइंड करेगा, बीटा भी बाइंड करेगा, अल्फा 1 अल्फा 2 के साथ भी बाइंड करेगा. यहाँ पे GQ जैसे काम करेगा, यहाँ GI जैसे काम करेगा, और बीटा 1 के साथ बाइंड करेगा, वहाँ GS जैसे काम करेगा. ठीक है, तो दैट इज द प्रोमिस्क्यूटी ऑफ द लाइगेंड. मतलब ये बहुत सारे रिसेप्टर के साथ बाइंड करके काम कर सकता है. सो व्हाट इज स्पेयर रिसेप्टर? इट ब्लॉक्स ऑल द रिसेप्टर्स इन द रिसेप्टर ऑक्यूपेंसी इज देयर, और वहाँ KD50 करके एक टर्म आता है, स्पेयर रिसेप्टर. इट ब्लॉक्स ऑल द रिसेप्टर, ठीक है. और लाइगेंड कंसंट्रेशन दैट प्रोड्यूस इफेक्ट इज द EC50, ठीक है. तो KD50 इज मोर देन EC50. फॉरगेट अबाउट दैट. ड्रग डेवलपमेंट प्रोसेस, ड्रग डिस्कवरी होता है नेचर से, प्लांट एनिमल या फिर हाई थ्रूपुट स्क्रीनिंग से, या फिर रैशनल ड्रग डिज़ाइनिंग हम लोग करते हैं, वहाँ से ड्रग डिस्कवरी हुआ. Now the preclinical research trials will be there, animal testing and lab testing will be there, safety will be evaluated, then efficacy will be evaluated. In the toxicity study, in the hyperpharmacology, acute, subacute and chronic will be there within days, weeks and months. ठीक है. They follow the GLP guidelines. Now weight of the animals and the mice is 20 gram, rat is 80 gram, guinea pigs is 150 gram. This data we have to actually learn. ठीक है. So MRG is 20, 80 and 150. Rabbit is 1.5 to 1.8 kg and humans is 60 kg we take. For animal testing, when there is done preclinical studies, INDA application is been formed and human testing will be there after that is known as the clinical trial, which follows the GLP and GCP guidelines both, which is there in the Schedule Y and new drugs and rules of 2019 we have to know. So there are many changes have been there. According to this, clinical trial is done in 3 phases, basically 4 phases. 1, 2, 3, 4 is mandatory and 0 and 5 and non-mandatory. Phase 0 trial is microdosing trial, first in human trial. ठीक है. So basically what it happens, there is acting on the 2 to 5 healthy individual given in the subtherapeutic dose and 100 micrograms are given. Effect नहीं दिखा जाता, toxicity नहीं देखी जाती. Purpose is the pharmacokinetic study, that is target binding होता है कि नहीं. ठीक है. तो नॉर्मल इंडिविजुअल में ये दिया जाता है फेज 0. फेज 1, 2, 3 एंड 4 इज़ वेरी इंपॉर्टेंट. सेफ्टी दिखा जाती है सब में. ठीक है. यहाँ पे हेल्दी ह्यूमन को लिया जाता है फेज़ 1 में. फेज़ 2, फेज़ 3, फेज़ 4 में पेशेंट्स को लिया जाता है. वेरी इंपॉर्टेंट. फेज़ 1 में अराउंड 50 पेशेंट्स होते हैं. फेज़ 2 में 500, फेज़ 3 में 5000 और फेज़ 4 में अनलिमिटेड. वी कैन नॉट डिटरमाइन, राइट. ओके. और सबसे इंपॉर्टेंट बात ये होती है फेज़ 1 और फेज़ 4 जो होता है वो ओपन लेवल होता है, बट फेज़ 2 एंड फेज़ 3 आर RCT एंड ब्लाइंडिंग इज प्रेजेंट. Randomized control trial phase 2 and phase 3 में होता है and it is the blinding is present. In the phase 1 safety is done and maximum tolerable dose is been determined. This is most important. Route of the drug, that is pharmacokinetics, is determined but no efficacy, only safety is there. In phase 2 therapeutic exploratory trial इसको कहते हैं. इसका भी 2A और 2B होता है. बेसिकली इसमें एफिकेसी दिखा जाता है, डोज रेंज को एक्सप्लोर किया जाता है कि कहाँ से कहाँ तक हम लोग एक्सप्लोर रेंज कर सकते हैं. Phase 3 is the therapeutic confirmatory. This is the dose is confirmed by increase in the number of sample population. By increase in the number of sample population, efficacy is confirmed. So that is known as the therapeutic confirmatory. Phase 4 is minimum duration of 2 years. जितने भी बैन ड्रग्स होते हैं वो फेज़ 4 से ही निकलते हैं. पोस्ट मार्केटिंग सर्वाइलेंस कहते हैं, मार्केटिंग करते हैं जो, एंड फाइंड द हिडन और मिस साइड इफेक्ट. जो सेफ्टी, रेयर सेफ्टी मतलब वो स्टडी होती है, बिकॉज ऑल द रेयर साइड इफेक्ट्स विल बी सीन ओवर हेयर. सबसे ज़्यादा कॉस्टली कौन सा होता है? 3 नंबर. याद रखना, 3 नंबर सबसे ज़्यादा कॉस्टली होती है. देन 2 and 1. हेट्रोजिनस पॉपुलेशन एंड मल्टीसाइट ट्रायल जो होता है वो फेज़ 3 में होता है. दैट्स वाई इट इज़ मोस्ट कॉस्टली. बेस्ड डेटा ऑन सेफ्टी ऑफ ड्रग अगर बोले तो 3 to 1, एफिकेसी में 3 to 1, क्योंकि ज़्यादा पॉपुलेशन से, राइट. मोर द सैम्पल साइज बेटर द ट्रायल. हाइस्ट फेलियर रेट क्या होता है? सेकेंड में ही फेल होना स्टार्ट हो जाता है. थर्ड में बहुत जगह आके फेल कर जाता है हमारा ट्रायल, और 1 में बहुत कम. तो बेसिकली इट इज़ वेरी इंपॉर्टेंट. फेज़ 5 इज नोन एज द फार्माको एपिडेमियोलॉजी. बहुत जगह में नहीं होता है. इट इज़ जस्ट द एक्सटेंशन ऑफ फेज़ 4 एंड सप्लीमेंट ऑफ द फेज़ 4 फाइंडिंग इन द लार्जर पॉपुलेशन. और वो बहुत साल तक 5-10 साल से किया जाता है. फार्माकोविजिलेंस एज सच इफ यू विल सी दैन ड्रग में के साथ ADRs मतलब बाइंड ड्रग के साथ एडवर्स ड्रग रिएक्शंस होते हैं. विल मॉनिटर और अनवांटेड हार्मफुल इफेक्ट ऑफ द ड्रग को लिखते हैं, राइट. टाइप्स ऑफ ADR क्या होता है? टाइप्स ऑफ ADR में ऑगमेंटेड डोज एंड टॉक्सिटी होती है. ठीक है. हाइपोग्लाइसीमिया ड्यू टू इंसुलिन इज़ वन ऑफ द एग्जाम्पल. टॉक्सिटी इज़ प्रिवेंटेबल इन नेचर. साइड इफेक्ट जो सेकेंडरी इफेक्ट होती है. बी से बिजार होता है एनी डोज, जो प्रेडिक्टेबल भी हो सकता है, अनप्रेडिक्टेबल भी हो सकता है. प्रेडिक्टेबल अगर होगा तो दैट इज नोन एज अ साइड इफेक्ट. फॉर एग्जांपल मेगालोब्लास्टिक एनीमिया ड्यू टू मेथोट्रेक्सेट, बहुत कॉमन है. अनप्रिडिक्टेबल दैट इज द इडियोसिंक्रेटिक रिएक्शन, एलर्जिक रिएक्शन टू पेनिसिलिन, या जेनेटिकली डिटरमाइंड होता है, दैट इज अ बिजेयर. ठीक है. सी से क्या होता है? क्रॉनिक यूज ऑफ द ड्रग. क्रॉनिक यूज ऑफ द ड्रग से क्या होता है? पेप्टिक अल्सर ड्यू टू एनसेड. पेप्टिक अल्सर ड्यू टू एनसेड. तो एनाल्जेसिक नेफ्रोपैथी जो होता है, इट इज़ अ टाइप C टाइप, है ना. टार्डिक डिस्काइनेशिया इन न्यूरोलेप्टिक्स. टार्डिक डिस्काइनेशिया न्यूरोलेप्टिक्स इज ऑल्सो अ टाइप C टाइप. क्रॉनिक यूज ऑफ द ड्रग टाइप, एडवर्स ड्रग रिएक्शन. Type D is the delayed reaction. For example, teratogens or carcinogens, the use of any substance, any adulterants. Type E जो होता है end of use reaction. End of use reaction, that is the sudden stop of the given drug, right? So adrenocorticoid insufficiency due to sudden withdrawal of corticosteroids is the end of use reaction, that is the withdrawal reaction. Type F is the failure of drug action. Failure of drug action, that is the antimicrobial resistance in the MDR, multi drug resistance, TB. Okay. Now toxicity in the normal dose is known as intolerance. Toxicity in the normal dose is known as intolerance. Now there is something called drug schedules. It is a law. It regulates drug sales and purchase. Schedule G is for give you drugs and non-prescription drugs. H is the halt prescription drug. Without prescription they are not given. H and H1 is there in the TB drugs example, very important. You cannot sell this drug without the prescription. X is the narcotic or psychotropic drugs, is for addiction or abuse drugs. NRX means for the narcotics. Okay, chemical used this copy for himself for 2 years. Now the drug types, if you will see, there is drug types is the orphan drug, that is a drug for the rare disease. Orphans means rare, orphan disease are rare disease, so they need a specific kind of treatment, right? Placebo is the fake drug. It is the dummy medicine used in the clinical trial. Okay, in the RCT and blinding they use this kind of fake surgery is known as the sham surgery. Fake surgery is known as the sham surgery. Now test drug versus control, if you will see now in the randomized control trial. Okay, now the placebo is having no active ingredient. Blinding is to remove the bias. Okay, now counterfeit drugs is the illegal drugs. It may be spurious, misbranded or adulterated. Spurious drug is no active ingredient. ठीक है, नो एक्टिव मतलब 500 जहाँ होना चाहिए तो वहाँ पैरासीटामोल में 0 है, एक भी पैरासीटामोल का वहाँ पे मिलीग्राम में नहीं है. इनकरेक्ट लेबल और इंग्रेडिएंट मतलब क्या होगा, 500 होना चाहिए था 200 ही है. दिस इज मिस ब्रांडेड. एडल्ट्रेटेड मतलब क्या होता है, अनवांटेड इंग्रेडिएंट डाल दिया. फॉर एग्जांपल पिंक ड्रग, कुछ भी इसमें डाल दिया, उल्टा पुल्टा कुछ ड्रग्स या फिर लाइक सम एडिक्टिव सब्सटेंस वहाँ ऐड कर दिया, इस तरह से, राइट. एसेंशियल ड्रग एज पर WHO आर दोज ड्रग दैट आर सेटिस्फाई द हेल्थ केयर नीड्स ऑफ द majority of population. Available at all times, all doses or formulations. It is cost effective. Single medicine do not combine unless required. So we have a list of essential drugs और उसकी की तरह से दवाई दी जाती है. Now when to combine? We combine the rational fixed dose combination and the irrational fixed dose combination. The basic thing we have to understand कि यहाँ पे जो terminology है, there is synergism. Synergism, that means additive and supra additive. ठीक है, तो इन द एडिटिव वी से दैट 1 + 1 = 2, बट सुपर एडिटिव 1 + 1 = 3. तो दैट इज द सिनर्जिज्म एग्जांपल. द साइड इफेक्ट्स इज डिक्रीज, compliance is improved, resistance is decreased, so there is antimicrobial they see. Teratogenic drugs can be there, harmful for fetus in pregnancy. उसके बारे में डिस्कस करेंगे. पहले ये देखो, irrational fixed dose combination में there may be antagonism, toxicity increase, cost may be increase, pharmacokinetic indifference will be there, so T half and the route will be different. Now teratogenic drug जो होता है वो हम लोग जो डिस्कस कर रहे थे, right, so harmful for the fetus in pregnancy, and this is A, B, C and D and X. X is contraindicated in pregnancy, absolutely contraindicated. D is the life saving, can be given in the life saving moments. A is the safest in the pregnancy, which are given. Drug storage temperature to freeze a drug is less than -10 to -20 degrees Celsius. Cold is less than 5 degrees Celsius. Cool and dry is 8 to 15 degrees Celsius. Warm is 30 to 40 degrees Celsius. Excessive heat is more than 40 degrees Celsius. Now drug label versus drug promotional advertisement. Okay, drug promotional advertisement, how is different? Now all things are nearly same. All things are same: price, storage temperature, indication, side effect, all types. Quantity of drug cannot be assured. Expiry date will be there. Excipient, dose, generic name, brand name will be there in the drug level. But in the drug promotional advertisement, expiry date is not mandatory. Expiry date is not mandatory. That is important. Now, nutraceuticals. Now active ingredient of the food, say lycopene होता है टोमेटो में, विटामिन डी, फॉलिक एसिड, पेपरवेर, और आई क्या होता है, पी ड्रग्स, से सपोज पी ड्रग्स के बारे में पढ़ते हैं, ठीक है। एच हो गया न्यूट्रास्यूटिकल्स, आई इज द पी ड्रग्स इज द प्रिस्क्राइब ड्रग्स, डॉक्टर्स प्रिस्क्राइब दिस काइंड ऑफ ड्रग्स frequently, so they are familiar with the name and the composition. So these are the most commonly used drugs for by the doctor. These are the P drugs. Okay, so thank you so much. So general pharmacology, this is the last video.